So welcome to another installment in our series, The Power of Pivoting, Managing Through Crisis, the Hospital for Special Surgery's Response to the COVID-19 Pandemic. I'm Dr. Ronald McKenzie, an internist and rheumatologist at Special Surgery, who serves as the moderator for these discussions. So this is an unusual chapter in this cycle because it's the first in which I might have otherwise been on the other side, which is to say not the moderator, but rather an interviewee. And that is because today we're going to talk about bioethics. It occurred to me in planning this session that you may not know or have given much thought about bioethics at special surgery. Well, we are here today to tell you that yes, we do ethics at HSS, though generally with much less intensity than over the last 2 months, and with the participation of a larger group of individuals than you're about to meet. And that was because in order to address the bioethical demands imposed by COVID-19, we needed to have a stripped down version of our committee. So here present is the core group, which in addition to myself includes Drs. Douglas Green, who I think it's fair to say was our leader through this experience, Mary Chisholm, also an anesthesiologist with a background in clinical ethics consultation and an appointment in the Division of Medical Ethics at Weill, Cornell. That was especially important to our function. And Dr. Seth Waldman, who's the director of our pain service. I'm actually the only participant who doesn't come from the Department of Anesthesiology, Pain Management, and Critical Care. So welcome to all of you. So we were so busy that I found it hard to know where to start, but decided to ask Mary to say something about the formalization of our efforts and the integration of our committee with that of the ethics division at Weill Cornell Medicine.
Yes, thanks, Ron. I'd like to respond to that question. Yeah, I think that I was both privileged and fortunate to be both involved with you three individuals at HSS, and to be a member of the Division of Medical Ethics at Weill Cornell. So on the one hand, being on staff at HSS, I was participating with meetings that Doug had started to formalize beginning in the middle of March, and we were discussing the ethical framework needed in a public emergency and trying and dealing with questions of preparation, scarce resources, how the hospital needed to respond in terms of an ethical framework. And at the same time, I was participating in meetings at New York Hospital with the ethics division there, where they were already involved in clinical consultations with COVID positive patients and dealing with the planning of scarce resources and the possible need of forming triage teams. So I was able to introduce all of you to my colleagues there, as well as the fact that Doug was already knew, as did you, had a long-standing relationship with the chief of that division, Joe Finns. So I think that in a sort of in a team way, we reached out and were able to formalize a collaboration and began participating with them in meetings that were being held 4 times weekly. And since they were virtual, we were able to just be added into those meetings very quickly. Everyone else on our team received privileges to begin consultations at New York Hospital should the need arise for these triage teams, as once again in terms of preparing for that. So I think that it was a sort of a seamless organization and melding of the two teams, and it worked extremely well in terms of reviewing, reconciling policies, institutional policies, procedures, and discussing consultations that came up when we had to begin to think not so much in terms of patient-centered care, but in terms of the public good and that tension. And I think that it was that tension between prioritization of resources and patients in this particular emergency that became like the ethical issue that came to the fore over and over again, and we provided mutual support in that regard.
Yeah, I think I would certainly endorse that summary and that view. And just add one other comment, which is that I think all four of us found that interaction to be a highly educational one for all of us as well. I mean, we got parachuted in to the world of bioethics in a hurry and had to swim fast.
Yeah.
So, Mary, you alluded to a topic that I want to have some discussion around, and that has to do with the anticipated scarcity of certain critical resources. Now, included amongst those were the so-called personal protective equipment, or what everybody is now familiar with, PPE, the abbreviation. But it was, I think, the trepidation about the possible shortage of ventilators that really focused the bioethics community, at least initially. So I'd like to have Doug comment a little bit about that. What were the clinicians to do if there were not enough of them? And what were they going to do if they had to choose who would get one? And how were those decisions going to be made?
Right. Well, I think that the issue of scarce ventilators and scarce ICU care is not just ventilators, but the entire orchestration of ICU care. That was the major nightmare that we were confronting. And I think that we all recognized very early on that in the event of the reality of the complete unpreparedness of the public health system in the United States to face a pandemic on this scale, that looking at ventilator access, we all saw that this was going to be a huge problem. And it wasn't just us. One of the things that I think brought New York Hospital and HSS together was that they saw that they didn't have enough people to handle all the clinical ethics consultations they were going to need. And they wanted us very much to help them out in that. And also, they wanted us to sit on their ventilator triage committee. And so one of the things that we did very early on, before there was I think a great public awareness of the trouble that was on the horizon, was we started reviewing the ventilator guidelines that exist. You can find them on the New York State Public Health websites. There were guidelines written in 2015 on how to allocate scarce ventilator resources in the event of an influenza epidemic. And it's a 277-page, I think, document. And in looking at it and trying to see how it would fit in with the COVID-19 pandemic, it was clear that they were woefully inadequate to the task. And so I think that what we did in the beginning was to try to find a way to make them work in what we saw as the looming COVID crisis. And that occupied a huge amount of our time. And part of the problems with those were that they didn't really make it possible to carefully and adequately allocate scarce resources like ventilators. There were a lot of details within the guidelines, even though the guidelines had never been actually adopted by New York State. They still have them on their website, and they were driving everyone's idea of what we were going to be doing. But we also knew from people who had written those guidelines and were currently working with the governor's office on adapting them to the current crisis. We knew that there were revisions to those guidelines, but we didn't know what those revisions were going to entail. And the people who were writing them weren't really sharing exactly what they were going to be. But they wrote them and rewrote them. There were at least 9 different revisions to those. And it was clear that there were going to be some adaptations to COVID, but that still there were going to be some major problems faced by people like us on triage committees in allocating the ventilators to the people who needed them.
I suppose it's fair to say that fortunately we were spared the ultimate dilemma, as the surge did not finally exceed the supply, or maybe the supply barely caught up with the surge.
Right. Well, as far as ventilators went, and as far as access to ICU beds goes, we never reached the point where triage committees were having to make decisions on who got ventilators and who didn't. However, recognize that the ICU beds that were available were not ICU beds. The ICU doctors who were taking care of ICU patients were not ICU doctors. They went from dozens of ICU beds at New York Hospital to hundreds and hundreds of ICU beds at New York Hospital. There were psychiatrists running units. There were PhDs writing orders. And to say that we didn't really get to the point where we had to triage ventilators is correct, but we were already facing a major, huge crisis in the adequacy of the rest of an ICU orchestration. But I'm very thankful that we weren't called on personally in the middle of the night to meet as a triage committee and say, patient A gets a ventilator, patients B, C, D, E, and F will not get one tonight. That didn't happen. But we did oversee the inadequacies of ICU care in many different ways. And we saw that in many of the consultations that we heard about, not at HSS. HSS had an incredibly rich allocation of expertise, and everybody had a highly trained ICU doctor taking care of them there. All of our COVID patients in the ICU had an attending physician taking care of them, an attending ICU physician taking care of them. But at other places that didn't happen. And so we heard and participated in consultation reports from the other institutions where they faced unbelievable crisis as patients arrived 3, 4, 5 at a time into the emergency rooms of some of our sister hospitals.
Well, another thorny issue that arose was what to do with patients who suffered a cardiac arrest, or more frequently a respiratory arrest. And there were also issues pertaining to patients who were on a ventilator and not doing well and having to take them off. So how were these decisions to be made, and who had to make those decisions, and by what authority were they to make those kinds of determinations? Any one of you could tackle that issue. Doug, maybe you're the most familiar with it as well, because you certainly did a lot of the work on reviewing the do not resuscitate policies here at Special Surgery.
Right. One of the many things that we did as a committee was to work with the legal team and the administration on a bunch of different projects. One of them was rewriting our do not resuscitate guidelines, streamlining them. We took I think a 22, 25-page document and pared it down to 3 pages to make it easier for the healthcare team to deal on the fly with issues of resuscitation. But in getting those issues, getting the guidelines streamlined, we actually added some more robust protections of patients. So they were easier for the staff to use, but in recognizing that it was going to be a very stressful and difficult set of circumstances for our healthcare team, we also beefed up the protections of patients and within that, so that the ethics team was involved in the decisions of who the appropriate surrogate decision makers would be, which is for those people unfamiliar with the ICU and end-of-life issues, as most people are, it's often difficult to determine who makes decisions for patients who are incapacitated, and certainly patients on ventilators and ICUs are incapacitated, unable to make those decisions. And parsing out which people are the appropriate decision makers can be, it's a very detailed and onerous process. And as part of that, we also put together an initiative on having everybody come into the hospital with a healthcare proxy, and a healthcare proxy appoints a healthcare proxy agent. And those agents have a lot of power and influence on how decisions can be made. And when patients didn't have healthcare proxies, finding surrogates based on state guidelines on the hierarchies of surrogates. And we also worked with the administration, asked bioethics to oversee changes in how cardiopulmonary resuscitation was conducted at HSS. And we brought together the resuscitation committee and the ICU doctors, and we developed a process that would be more appropriate to a COVID-19 pandemic and the exposure of staff to infectious patients. When we learned from both the SARS epidemic and the MERS epidemics of the past that the resuscitation team, particularly the people who were involved in securing the airway and intubating patients, were at high risk for exposure. And we developed a guideline which turned out to be almost exactly the same as the American Heart Association's guidelines that were being developed simultaneously.
All right, so inevitably, it would become clear that certain patients, usually, but not always, older individuals with various chronic medical conditions were not likely to survive. And in those circumstances, the goals of care would require reassessment. Now, the frontline physicians would often rely on palliative care experience, and our hospitals and, our anesthesiologists and pain service specialists have that training. So I'd like Dr. Waldman to tell us a little bit about how those problems were approached.
Well, if I could, I'd also like to just say one word or two about what this looked like to me. I was the newest person on the service back in March. I just finished my graduate training in bioethics a couple of months earlier, and saw my last day of normal patients, as we all did, on March 13th. But on March 14th, I got a strange call from Doug Green in the morning with his 275-page document saying, perhaps you ought to prepare yourself to read this document. And within 2 weeks, had sort of battlefield privileges at New York Hospital as a medical ethicist, which was definitely outside of my scope of experience. One thing, fortunately, which was not outside of the scope of my experience and also the experience of our pain team at HSS, is that we had a very robust pain service, probably per capita, per bed, one of the more or most dense pain services anywhere in the country. And so we had a pretty deep bench of people, doctors and nurses, who are board certified in pain and in palliative care. And when it became apparent in March that HSS was going to be temporarily out of the orthopedic surgery business and in the intensive care and pain management palliative care business, we really had logistic issues only, but not staffing issues. We had a staff which was fully ready to have goals of care discussion with patients. The logistic issues being, of course, their families weren't there, or sometimes their families hadn't been identified or couldn't been identified. As you heard, some people did not have healthcare proxies. We didn't know who their surrogates were. And so there were logistical barriers to that. And of course, the infectious barriers because of COVID specifically. But I think that the inpatient pain management team was ready to pivot when palliative care, which always coexists with all care really, but particularly with intensive care, at moments when intensive care was going to be withdrawn because there was no hope of a meaningful recovery, the palliative care team was able to seamlessly advance their care, not step in because it had been there before, but to advance more palliative measures as life-saving efforts, ventilation and other things were being withdrawn.
Well, it's certainly the palliative care team and pain service played a very, very important role here in the care of these patients. So Mary, I thought maybe we could conclude this session by you giving us a little summary of the kinds of patients that we were actually consulted on. I think the listeners might be interested in getting some sense of the flavor of the clinical problems.
Well, I can think of a few in particular. One was it's a bread and butter type of ethics consult, but then it's put in the context of COVID. We had an unrepresented patient, meaning we had no surrogate for this patient, and this patient was also incapacitated, meaning they couldn't make decisions for themselves. So we were consulted on that patient because he rapidly decompensated and had to be intubated and placed on a ventilator and taken to our ICU while at HSS. But and so we were, because without anybody there as a decision maker, the team wanted to know how do we proceed. But I would say that in that particular case, really because of the efforts of the HSS staff, they were able through social services to actually find a cousin for that patient who, when approached, was willing to serve in the role of the surrogate decision maker. So it was sort of it was a situation in which things worked out well for the patient in terms of being represented. There were also two other instances. One was a patient, as Seth mentioned, where the team felt that the patient would not have an opportunity for meaningful recovery. So from the team's point of view, this patient was someone that should be moved to DNR, should be allowed to die, basically. And I think you were actually the ethics consultant in that case, Ron. The son was the healthcare agent and felt very strongly that he definitely wanted medical care to continue. He wanted for us to really assert everything that we had in order to continue this woman's life. And he felt that for him, the value of life was what was most important. He was able to articulate that for her, and so that's what the team honored and represented in the way they handled that particular case. And then on the other end, there was a family that felt very strongly for their patient that he was on a ventilator and that he would not want that. So once again, in that particular instance, ethics was involved because it was a withdrawal of life support, and so the ethics team was very involved in just confirming that with the decision makers that this was in fact in line with what the patient's preferences and values.
Well, very interesting. Well, listen, I think I can bring this to a close. Doug and Mary and Seth, thanks so much for doing it. And I thought I would just make a final comment about our experience, and I think that you would all share this view. But at Special Surgery, we had the expertise to do this. We had the resources to do this. We also had the luxury of a little time, never really becoming completely overwhelmed. But I think most importantly, what we had was the culture to do this really well, and I think we did. So thanks so much for being with me today.
Thank you, Doug. That's you, Ron. Thank you.